own mother had cancer. She died in her early 60s. It's quite a long time ago. And she lost her oral route, and everything was a train wreck. So, the Macy's even closer to my heart because I know if we had had that option to be able to medicate her to cancer, um, sh we wouldn't have had the experience we had. So let's start there as kind of the starting point for the things that I love about the Macy catheter, which I do have in my living will, because that's how much I think it benefits comfort at end of life. I mean, if I could, to be honest, for anyone who's on more than just a very scant amount of medication for very low level end of life labor symptoms, I think that the Macy catheter is a good standard of care for best outcomes, pure and simple. I was working in the evening and got a call that there was a patient who had, I believe, metastatic cancer, and he was home in a home setting, surrounded by lots of family. And he had very quickly changed and lost his oral route, and he was having agitation that there were 3 calls into triage, and they kept giving him more med, and it wasn't touching him. He was just getting worse. He was in bed, and he was cockeyed in bed, and he was rolling around, and he was kind of gurgly from all the meds they gave him. And I looked at the family. I said, I know how to make this better. We're going to make this better. Okay. I'll be right back. And I went out to my vehicle and I grabbed a Macy, and I very quickly went in, got the Macy in. I said, I'm not even going to teach you this. I'm putting it in. We're going to medicate him, and then I'm going to talk to you about this. But let's start getting him comfortable first. And they were all very happy about that. Had the Macy in 4 minutes, not even that, right? And then we talked, and as we talked, and I was looking at setting up the plan and stuff. Within 20 minutes, he was settling. You could feel the static of his symptoms and the anxiety it was causing his family, who, imagine these people who love him, sisters, wife, adult children, in tears for watching this. And they were so appreciative. They felt like they'd watched a miracle. I mean, this guy had been rolling around, moaning uh, for hours, but he was comfortable. He was comfortable and asleep by the time I left the house. That's a very good example of a situation for which I think it was created, that Brad Macy discovered with an agitated patient that he just couldn't get comfortable via the sublingual route. I am so grateful that we have this. I never have less than 2 on hand because I get nervous. If I have less than 2, then my stop. So, because when it's needed, it's needed. Back in the day, when there were no other options, we had to view the sublingual route as good, good enough. But now we have another option. When we try to manage high level symptom, high burden symptom, like for people who have cancer, they're on, you know, long acting morphine which is you, you have to literally put a milliliter of fluid. And if we're only talking opiate, but we also have other meds that people need. They need to have what we call an adjuvant, lorazepam, haloperidol. So that there's more fluid, and that fluid, it can be to the tune of a milliliter and a half every 2 to 4 hours to meet that need. Now, Mother Nature is very smart, and Mother Nature dries us out. So we're making a very small amount of sputum at end of life. However, we are responsible for creating very excessive um, terminal secretions, because a portion of that medication goes into the bronchus. And I have come upon patients who have been treated that way, and their secretions are ridiculously bad. I can't even normalize that. Like, oh, this is normal. That's not normal. Actually, that is not normal. That level where you can actually see fluid in the back of the person's throat if their mouth is open, that's from the medication and probably inflammation that it creates too. So the second really good thing, now we're not throwing high volumes of liquid into somebody's gullet when they're dying. And the thing is, once it gets to a certain amount, forget the sound effects, but it can induce people to cough when it's really bad, because that's the natural response to the body will do if it can. And that disrupts the person's ability just to rest if they're having to try to clear their airway because there's so much fluid. So the third thing is it allows medication dosing to be done 24/7 without disturbing the patient. So now, no matter what position that person's in, no matter, they don't have to wake them up. We don't have to worry about them spitting it out. We don't have to worry about vomiting. We don't have to worry about them drooling it out of their mouth because they're on their side. None of that. We have full control. The fourth is oral comfort. Now, between here and here, as a hospice nurse, between the mouth and the throat, I feel pretty helpless to help people when they're dying. I know that throat is very dry and the mouth is very dry. And, I don't know what their awareness is of that, but I do know that it's probably not pleasant to have bitter medication put into a dry mouth, a dry throat that's heading down into the bronchus because they have no way to control their airway. And so just the not having that bitterness in their mouth, they can't tell me, ooh, this is really bad. Nobody's been able, nobody, but they'll grimace. They'll grimace when you put that in there. And so that is another benefit from the catheter. This device, I have had no bad outcomes, not one. I have not had anything but positive reviews from my patients and their families. So the way I explain it to families is I share with them, I say, look, this is going to sound odd, but the rectal route is a very good route for medications. It is better than this. We get better absorbency. We can dose them anytime and take full control of that route. We don't have to wake them up or disturb them. We can just keep them comfortable. Keep them comfortable. We're not going to make all those terminal secretions and put that nasty chemical in their mouth. I don't know what that's like, but it's bad enough. I have it on my living will, but I'm not letting anybody do that to me. And okay, I'll admit that does push it over the finish line when I say it's in my living will, but I would recommend any hospice nurse put that in your living will. It's a better way to die. It's a better way to die. This was a nurse that created this. This was a hospice nurse that created this. And I have seen no downsides